Cough performs an essential protective function for human airways and lungs, prevents aspiration of foreign material, and actively clears lower respiratory tract. Without an effective cough reflex, we are at risk for retained airway secretions and aspirated material predisposing to infection, atelectasis, and respiratory compromise. Yet, at the other extreme, excessive coughing can be physically exhausting. It can be complicated by emesis, syncope, muscular pain, or even rib fractures. An unrelenting cough can aggravate low back pain, abdominal or inguinal hernias, and urinary incontinence. Picture the delicate architecture of the airways. Both chemical stimuli like capsaicin and mechanical stimuli, such as mucus or particulates in air pollution, can initiate a cough. This process begins at the microscopic level, where cationic channels, like transient receptor potential channels, and adenosine triphosphate activated ion channels, known as P2X3, function as sensory neuronal receptors. When triggered, these receptors transmit signals centrally via mechanosensory A delta fibers and chemosensory C fibers. These afferent nerve endings are everywhere. They richly innervate the pharynx, larynx, and airways, down to the level of the terminal bronchioles, extending deeply into the lung parenchyma. Interestingly, they are also located in the external auditory canal, innervated by the auricular branch of the vagus nerve, known as Arnold's nerve, and within the esophagus. Once activated, sensory signals travel via the vagus and superior laryngeal nerves straight to a region of the brainstem in the nucleus tractus solitarius. Integrated neural networks then process this sensory input into the conscious sensation we know all too well, the urge to cough. The resulting efferent limb of the reflex is a highly orchestrated series of involuntary muscular actions, though input from cortical pathways also makes a voluntary cough possible. First, the vocal cords adduct, leading to transient upper airway occlusion. Expiratory muscles forcefully contract, generating positive intrathoracic pressures as high as 300 millimeters of mercuro. Suddenly, the laryngeal contraction releases, and rapid expiratory flows are generated that actually exceed the normal envelope of maximal expiratory flow seen on a flow volume curve. Bronchial smooth muscle contraction and dynamic compression narrow the airway lumens, maximizing the velocity of exhalation. Taking a deep breath just before a cough optimizes expiratory muscle function. At higher lung volume, maximum velocity is located in the central airways. A series of repetitive coughs set successively lowers the lung volume and sweeps the point of maximal expiratory velocity progressively further into the lung periphery. This leads to clearing of secretion from the deeper and peripheral portions of the lungs. A weak or ineffective cough fundamentally compromises the ability to clear lower respiratory tract secretions. This leads to pooling of uncleared mucus and aspirated material dangerously, congesting the lower respiratory tract. It predisposes patients to more serious infections and their sequelae like atelectasis. There are many reasons this vital clearance mechanism might fail. The most common causes include central respiratory depression, caused by anesthesia, sedation, or neurologic disease, primary respiratory muscle weakness, chest wall or abdominal pain, chest wall deformity, such as severe cough scoliosis, impaired glottic closure or tracheostomy, abnormal airway secretions, ciliary dysfunction, tracheobronchomalacia, bronchiectasis, tracheal or bronchial stenosis. Sometimes a patient can generate a normal expiratory velocity, but the cough still fails to clear secretions completely. This failure may be due to abnormally viscous secretions found in cystic fibrosis, ciliary dysfunction like primary ciliary dyskinesia, or structural abnormalities like tracheomalacia, where there is excessive expiratory collapse of the trachea during a cough. When a patient presents with a cough, its companions often point to a diagnosis. For instance, a cough accompanied by wheezing, shortness of breath, and chest tightness after exposure to a cat or allergens strongly suggests asthma. Yet, when cough is the dominant or sole symptom, we look to the calendar. The duration of the cough provides retrospectively vital clues to its etiology. Acute cough, lasting less than 3 weeks, is most commonly due to a respiratory tract infection, aspiration, or inhalation of noxious chemicals or smoke. Subacute cough, lasting 3 to 8 weeks, is often a residuum of tracheobronchitis, such as pertussis or a post-viral tussive syndrome. Chronic cough, lasting more than 8 weeks, may be caused by a wide variety of cardiopulmonary diseases, including inflammatory, infectious, neoplastic, and cardiovascular etiologies. Sometimes the clues lie in the patient's history. In a long-time cigarette smoker, an early morning, productive cough suggests chronic bronchitis. A dry, irritative cough that lingers for more than 2 months following respiratory infections is known as a post-bronchitic cough and is a very common cause of chronic cough, especially in winter. Useful historical questions include the circumstances surrounding the onset, such as sudden or insidious or any specific triggers. What makes it better or worse, for example, during night or with exercise, and whether it produces sputum along with its characteristics, such as amount, color consistency, or presence of blood. Our physical examination seeks clues of cardiopulmonary disease, like wheezing or crackles. We examine the auditory canals and tympanic membranes for irritation stimulating Arnold's nerve, the nasal passageways for rhinitis or polyps, and the nails for clubbing, because cough can be a manifestation of systemic diseases like sarcoidosis or vasculitis. A thorough general examination is essential. Evaluating a chronic cough merits a chest radiograph. This is because the list of diseases causing persistent cough without other symptoms or physical abnormalities is long. It includes serious illnesses such as sarcoidosis or Hodgkin's disease in young adults, lung cancer in older patients, and worldwide pulmonary tuberculosis. If a patient has a chronic productive cough, we examine the expectorated sputum, as determining the cause of mucus hypersecretion is crucial. Purulent sputum should be sent for routine bacterial culture, and sometimes mycobacterial culture. Mucoid sputum can be examined cytologically to assess for malignancy oropharyngeal aspiration and to distinguish neutrophilic from eosinophilic bronchitis. Expectoration of blood, whether streaks, mixed with secretions or pure blood, requires a special approach to assessment entirely. What happens when the chest radiograph is perfectly normal? Traditional teaching dictates that ACE inhibitors, postnasal drainage, gastroesophageal reflux, and asthma account for more than 90% of these cases. Let us explore these culprits, starting with ACE inhibitor-induced cough. It occurs in 5 to 30% of patients taking these agents and is uniquely not dose-dependent. ACE normally metabolizes bradykinin and substance P. Preventing this may lead to their accumulation, sensitizing sensory nerve endings. Any patient with a chronic unexplained cough on an ACE inhibitor requires a trial period off the medication, regardless of when the cough began relative to starting the drug. Angiotensin receptor blockers do not cause cough and serve as a safe alternative. Then we have postnasal drainage, which can stimulate receptors in the hypopharynx or be aspirated into the trachea. The broader term, upper airway cough syndrome, implies that chronic inflammation in the nose and sinuses can cause cough even without physical drainage into the pharynx. Clues include a sensation of postnasal drip, frequent throat clearing, sneezing, and rhinorrhea. Next is gastroesophageal reflux. Reflux of gastric contents into the lower esophagus may trigger cough via reflex pathways in the esophageal mucosa. Laryngoporangeal reflux, reaching the pharynx, can cause aspiration, chemical bronchitis, and pneumonitis, eliciting cough for days, though this is uncommon. Symptoms like retrosternal burning, frequent eructation, hoarseness, and throat pain point to reflux. Yet, reflux can be entirely silent. Glottic inflammation on laryngoscopy is a nonspecific finding. Proper quantification requires invasive measures like esophageal pH probes, manometry, and non-acid reflux testing. The third major cause of chronic cough with a normal chest radiograph is cough variant asthma. While asthma usually presents with a cough among children, cough alone as a manifestation of asthma is not common among adults. When it does occur without wheezing or shortness of breath, it is termed cough variant asthma. The history usually ties the onset of the cough to typical asthma, triggers, and resolves when the exposure ends. Objective testing, such as spirometry showing variable airflow obstruction or reversing with bronchodilators, or a negative bronchoprovocation challenge with methacholine, can confirm or exclude it. Home expiratory peak flow monitoring is also a cost-effective method for reliable patients. Finally, eosinophilic bronchitis causes chronic cough with a normal radiograph. This uncommon condition features sputum eosinophilia in excess of 3% without airflow obstruction or bronchial hyperresponsiveness. Measurement of elevated exhaled nitric oxide can detect this airway inflammation and predict a favorable response to treatment. Recently, the concept of chronic cough hypersensitivity syndrome has emerged. This syndrome emphasizes the role of sensitized sensory nerve endings and afferent neural pathways, akin to chronic neuropathic pain. It presents with a dry or minimally productive cough, a tickle or sensitivity in the throat, and worsens with talking, laughing, or exertion. It is more common in women, can last for years, and lacks specific diagnostic criteria, making it a diagnosis of exclusion. Treatment for a chronic cough with a normal chest radiograph is often empirical, targeted at the most likely cause derived from the history and examination. Therapy for postnasal drainage depends on the etiology, infection, allergy, or vasomotor rhinitis, and may involve systemic antihistamines, decongestants, antibiotics, nasal saline irrigation, and nasal sprays containing glucocorticoids, antihistamines, or anticholinergics. For treating gastroesophageal reflux, medications to improve gastric emptying or alginates to impede reflux flow are used. Acid neutralization using antacids, H2 receptor antagonists, and proton pump inhibitors are most used. Lifestyle adjustments, including dietary changes, and elevating the head and torso during sleep are also helpful. Cough variant and eosinophilic asthma typically respond well to inhaled glucocorticoids and the intermittent use of inhaled beta-2 agonist bronchodilators. If a patient fails to respond to these targeted treatments, or if appropriate testing has excluded these common causes, the next step is a chest CT. A CT scan can reveal diseases missed on an X-ray, such as early interstitial lung disease, tumors, bronchiectasis, and atypical mycobacterial pulmonary infections. Lastly, let's discuss few commonly used cough suppressants. Currently available cough suppressants are only modestly effective. The most potent are narcotic suppressants like codeine, hydrocodone, and morphine, which act directly on the brainstem's cough center. However, their appeal for long-term use is severely limited by side effects, such as drowsiness, constipation, and the potential for addictive dependence. Dextromethorphan is an over-the-counter, centrally acting alternative with fewer side effects, though it boasts less efficacy than narcotics. It acts on a different site and can actually be used in combination with narcotics if necessary. Benzonatate, another option, is thought to inhibit the neural activity of sensory nerves in the cough reflex pathway. While generally free of side effects, its effectiveness is variable and unpredictable. We can even use inhaled lidocaine, an inhibitor of voltage-gated sodium channels, to provide transient suppression, but it carries an increased risk of aspiration due to the associated oropharyngeal anesthesia. For patients suffering specifically from cough hypersensitivity syndrome, treatments attempt to inhibit the hyperactive neural pathways. Small trials have shown benefit from the off-label use of gabapentin, pregabalin, or amitriptyline. Novel cough suppressants under development include neurokinin-1 receptor antagonists, transient receptor protein vanilloid 1, or TRPV1 channel antagonists, P2X3 channel antagonists, and novel opioid and opioid-like receptor agonists. And that's our comprehensive dive on approach to a patient with cough. If you found this video valuable, please take a moment to hit the like button and subscribe for more high-yield content. Thanks for being part of our community, and we'll see you in the next video.